Really delighted to be talking about some of the work that's happening at the KW4. And just in case some of you are wondering, the KW4 actually stands for Kitchener, Waterloo, our two large cities, and then our amazing surrounding townships of Wilmot, Woolwich, and Wellesley. So in terms of the agenda for today's discussion, really we're going to start by sharing a bit of information about the KW4 OHT, and then talking about how we've used data to help inform and develop some of our health equity focused work. We're going to share an example of one of our initiatives focused on our priority neighborhoods, and then finally some lessons learned that make doing this work a privilege and an opportunity, but also a bit of a challenge. So let's get started with respect to our population. So the KW4 OHT is one of the fastest growing cities in the province as well as in the country. Looking at our census data, we know that we had a 5-year growth rate that's approximately 11%. And when you compare that to the Ontario and the Canadian average, you can see that we're growing at a really fast rate. And that when you look at the growth, what's interesting is that in particular, this growth is tied to our newcomers and individuals coming into the country. So almost 53% actually of our growth is determined by the newcomer growth that we've had in our cities and region. So immigrants, as we talked about, account for a large portion of our population. And certainly in our overall in our population in the last 5 years, we're continuing to see this grow. What's important is that of the new immigrants, we have seen that this isn't just students. So we have 2 large universities in the region, but we've also seen from an economic perspective that we have individuals coming from Afghanistan, Syria, as well as the Ukraine most recently. And so this is really starting to shape our equity discussion, if you will. So really, we needed to better understand some of the challenges and opportunities that were faced, that our newcomers were facing. And so what we did last year was we ran a project looking at what were the experiences of newcomers, because we know that when our newcomers arrive in Canada, their level of health is actually greater than 4 or 5 years after that. And that these declines in health that are seen 4 or 5 years after are actually tied to the social determinants of health. So in the summer of 2022, we created a process where we could journey map our newcomer stories to better understand what was working, how they interacted with the healthcare system, and the opportunities for improvement. We also wanted to understand our newcomer population. And so we know that in looking at the data related to who's coming from where, we understood that many of our newcomers were very well educated, that their formal education was actually higher than the average of the individuals living in KW, and that they were very digitally savvy. And so that was important when we started to think about some of the work that we wanted to do. What we learned from our interviews was that many of our newcomers were keen to self-navigate, and that often weren't able to find the information themselves in order to make decisions, that they were dependent on our systems that were very people focused and going into certain places, etc. And so trying to think about that as we look at how do we need to evolve our systems. We also learned that many of them had challenges accessing healthcare services, in particular finding access to primary care services. But that although that was important, it was equally, if not as important as finding a job, having access to shelter, access to social supports. And all of them talked about mental health challenges and the difficulty in accessing the mental health services across our region. So our hypothesis was that if we could better understand the needs of our newcomers in the first 5 years, that we could maintain their health and possibly prevent the decline. Melissa spoke about listening to our population and then working with them to build change. And really, that's what the newcomer journey mapping is about. Our recent data shows that the highest portion of our marginalized population, which includes Indigenous peoples, visible minorities, newcomers, live in 4 priority neighborhoods. And so by looking at the data in terms of health data for these neighborhoods, we could start to understand what were some of the challenges in these neighborhoods. So for example, these neighborhoods represent about 18.4% of our population in KW4, but they represent almost 35% of our ambulatory care visits to our hospitals. And this includes angina and asthma, COPD, diabetes, and a couple of other conditions as well that often we see ED visits for. We also recognize that this almost 18.5% of population represents over 32% of our ALC visits, our ALC. And so we're starting to see that these individuals, once they're in the hospital and are finished their care, can't necessarily have the resources or the supports to be able to go back into the community. We also know that 30.4% of the inpatient days are attributed to these four priority neighborhoods, and that finally, almost 44% of our frequent emergency department visits for mental health and addictions is tied to these priority neighborhoods. And then as of June of this year, we have data that shows that these neighborhoods account for 30% of the patients that are registered in Healthcare Connect in hoping to find a primary care provider. Kim spoke about cancer screening, and certainly in these neighborhoods, we have the lowest cancer screening rate in our region, and it's 14 to 17% lower than the screening rate for some of our more better performing neighborhoods. So you're really starting to see the disproportionality of health equity playing out in these neighborhoods. So for us to start to focus on this work and share this information, we wanted to first bring together our providers in these neighborhoods so that we could start to share some of this data. We wanted to understand what were the services that were being offered, how were they connected. Knowing a little bit more about these neighborhoods was also very important to us. Do they have access to food? What's the housing situation like in these neighborhoods? Is there easily accessible public transportation? So what we did was we brought together our providers who deliver care in these neighborhoods, but we also partnered with the University of Waterloo to better understand best practices and evidence-based care related to social prescribing and the importance of the social determinants of health. Once we were able to pull these groups together, we wanted to work with our community agencies and our community providers as well to start to build and develop some personas around the priority populations within these neighborhoods. So through a series of several workshops, many of which were in person, and we had over 40 to 50 people attend these workshops, each of them, we started to develop 3 pathways that helped to, if you will, put a face to some of the challenges that were being faced in these communities. And we were able to develop 3 personas. The first one was related to a senior with a heart failure. And this is one of the largest ED visit causes in our region. Certainly a diabetes pathway related to our newcomers, because we know that chronic disease in our newcomers is growing at an alarming rate. And then a third one that really came from, I would say, our community partners and our community members was youth transitioning to adulthood and accessing mental health services in that transition spot. So these pathways focus on supporting community members within the community with the goal to improve overall wellness, but also reduce hospital admissions and readmissions. Some of the lessons learned, first of all, we know to achieve improved health and wellness, we need to take a population health approach. So an episodic or a reactive approach really can be quite limiting and doesn't allow us to create a learning health system. So how do we consider traditional funding models using a population health approach? Second, a population health approach with focus on health equity helps us understand the issues faced by our communities and create more comprehensive care plans that impact our system indicators. If we continue to focus on system indicators without taking the time to understand the hyperlocal or population differences, we won't actually be able to improve the system and move the needle. For some, this work may feel new and requires that all levels of government are aligned with respect to their priorities and goals. It's not an or, but it's an and. So, for example, when we talk about translation services, which I'm sure many of you are familiar with, having access to a preferred language is important, regardless of whether you're going to speak with your primary care provider or you're looking for a job. And yet, one of the common tension points that we see is that translation services is seen as a health function only, rather than something that, as a newcomer, would improve your health and wellness overall. And finally, with respect to evaluation, it takes time and requires providing support and education to our non-traditional partners. So for example, working with our settlement agencies, as well as our hospitals and our community agencies, including our grassroots agencies, is a very different approach than doing research or performance measurement and management within a hospital alone, for example. And so the level of understanding and knowledge can vastly vary. And so how do we manage that in order to ensure that we're able to measure and evaluate authentically? And then finally, this is a long journey. And the indicators that we use may need to expand to consider non-traditional healthcare indicators. So for example, by using the quintuple aim to allow us to better understand our impact, we can start to influence the system and improve health equity for all in our communities. Thank you.